All right, thank you. I wanted to talk about a summary of all non-myeloablative stem cell transplants done at one center in Chicago, Northwestern. It's a retrospective analysis of prospectively captured data from a single center for all our patients, both on and off study. The total number is 507. Originally, it said 511, but there was a neuromyelitis optica and a primary progressive, and those were removed. So it's 507 patients between July of 2003 and October 2019. All patients were between 18 to 60 years old with an EDSS between 2 to 6.5 plus. They had failed a first-generation DMT and 2 relapses in the prior year, or had failed a second or third-generation DMT and 1 relapse in the prior year, or they did have an EDSS greater than 6.5, but were relapsing or remitting with numerous enhancing lesions. Or finally, there were a group of patients that were newly diagnosed SPS. So basically, if a patient had a diagnosis of secondary progressive MS, we did not see them, but there were several patients sent to us with relapsing remitting, and we newly diagnosed them with SPS. And that group we also did off study. Everybody else was relapsing remitting. Let me see. Did it go forward? Yes. So the regimen were all non-myeloablative, all contained Cytoxan, 200 milligrams per kilogram. The first 26 patients were Cytoxan Campath, but due to a high incidence of late ITP, most of which occurred within 2 years, but one did occur as late as 3 years out. After that, there was never another case. We switched Cytoxan ATG, got rid of the Campath or Lemtrada, alemtuzumab. It's all the same drug. We got rid of that with ATG to try to decrease ITP, and it did markedly decrease. But to try to further improve it, we even modified that Cy-ATG in 46 patients with IVIG, or in another 63 with rituximab. And this is a summary of all of them. We didn't change the regimen to improve outcome. We did it to see if we could affect toxicity, that is ITP. And in all of these cases, the ATG maximum dose was 6 milligrams per kilogram. There was no CD34 selection, so we never had a problem with Epstein-Barr virus PTLD, and we did monitor that. And that's important because non-myeloablative regimens can be just as intense as myeloablative, and when you exceed 6.0 milligrams per kilogram of ATG with CD34 selection, you do get PTLD or Epstein-Barr reactivation, as shown in a recent paper this year out of London in Neurology, as well as shown in the original randomized trial for scleroderma, when again, high doses of ATG were used with randomization. But when you don't do that, you could see in these 507 patients, we never had a case and we don't even follow it. Here are the patients. 414 were relapsing remitting, 93 were newly diagnosed SPS. Again, we refused to take secondary progressive MS, but referred to us with a diagnosed relapsing remitting. We diagnosed them as SPS. Again, male to female numbers, which would be expected. Most of the patients were Caucasian, but there were minorities. The age for relapsing remitting was a little bit younger, so it would be expected age 35 versus 40. For secondary progressive, duration of disease was again longer with secondary progressives at 11 years mean versus 6.3 with relapsing remitting. Number of prior DMTs again was a little more, 4.15, and the EDSS was again, as would be expected, worse, 3.87 mean for relapsing remitting, 5.2 for secondary progressive. When we look at prior disease modifying therapy, again, all these patients had some sort of prior treatment, either an interferon or Copaxone. 60% had Copaxone, and everybody else had some type of interferon that's listed here, as well as often other drugs. 40% approximately had Tysabri, 30% Tecfidera, 22% Gilenya, and a variety of other drugs, including Ocrevus and Novantrone and even Lemtrada and Cladribine, as you can see. having trouble getting the clicker to work. The treatment-related mortality was 1 of 507. That's 0.2 or 0.19%. That was a patient that died due to Legionella acquired from the water in the shower head, and that was during the transplant. The overall survival is 99.1%. There were 2 late vascular deaths well after engraftment, well after hospital discharge, more than 1 year after transplant. One was a cerebrovascular accident with non-compliance to hypertensive drugs. The other was a myocardial infarction. There were 2 cancers. One was a colon cancer 3 years out. One was a T-cell lymphoma more than 10 years out. And that patient was one of the 26 that had gotten alemtuzumab, because the most common cause of death that you will see whenever you look around a room, most people will die of vascular death or a cancer death. I don't think these numbers are increased. Perhaps it could be argued that the alemtuzumab could have contributed to a late T-cell lymphoma. I don't know. It's something to keep in the back of mind, especially for all those patients that get alemtuzumab as a monotherapy because of prolonged CD4 cytopenias. No patient developed myeloablative syndrome, leukemia, or bladder cancer. In terms of infections during the period of neutropenia before hospital discharge, there was only 1 of 507 patients that had a bacteremia. That was due to Klebsiella. It was not resistant to any type of antibiotic. We attribute this very low incidence of bacteremia to no mucositis. So here's the infections for the first 100 days after hospital discharge. As you can see, there were really mucosal surface infections, upper respiratory tract and urinary tract. Most were bacterial, but as you can notice here in the center, there were some respiratory viruses. They were all handled as outpatient without hospitalizations. Next. We did have some secondary autoimmune diseases. 53 patients before transplant had a history of hypothyroidism. 16 developed it after transplant. I'm not sure that's going to change the natural history, but if you look at Graves' disease, 8 had it before transplant, 15 developed after, and 3 had hypo followed by hyperthyroidism. So I think Graves' disease and possibly hypothyroidism is something to watch for, and check thyroid functions every year when they return for follow-up. In terms of ITP, as you can see, the incidence was 14% with an alemtuzumab regimen. When we got rid of that with ATG, depending on which regimen we used, it was 0 to 2.8%. So you still should be aware of that. The risk is much less, but it can still happen. And when it does, it almost always occurs within the first 2 years or within the first 3 years. And the best drug that it seems to respond to very quickly is rituximab. Next slide, please. Here's the relapse-free survival between the 414 with relapsing remitting versus relapse-free with secondary progressive, 93 patients. So you'd think, well, okay, this is great. With secondary progressive, they had less relapses, but that's because that disease normally has less relapses. It burns out with time. So whenever you're reporting secondary progressives and saying there's a low number of relapses, I'm not sure that's due to your treatment. That's the natural history of secondary progressive, whereas you can make that case with relapsing remitting. Next slide, please. If we look at progression-free survival, you can see the progression-free survival was very high after transplant with the 413 patients relapsing remitting, whereas we still had ongoing progression of disease with secondary progressive. So whether we really changed the natural history of secondary progressive or slowed progression is unclear to me. Next. And so when we look at the different regimens you use, the majority of them, that should be 411, but anyway, not 511. You can see that the most of them were Cy-ATG, and here's where we talk about all the regimens here. They all follow the same curve. Some of them just by random choice had a higher mean, but they all slope down the same curve. And when they go out to 5 years, they all end up at the same place. So the efficacies of the different regimens, I would say, appeared to us, there's no randomization there, to be rather similar. Next slide. When we looked at the difference, however, between the patients with relapsing remitting here, 400 and 14 versus in red, secondary progressive, there was a big difference in improvement of the EDSS, marked improvement in relapsing remitting, much more than 1 point, and not much of an improvement in secondary progressive. And these were newly diagnosed secondary progressive. Next. And if we look at just at the relapse remitting 414 patients and break it up by EDSS, those who came to us with an EDS of 2 to 4, you can see here they still improved. Those who had an EDS of 4.5 to 6, you can see had a marked improvement with us, as well as those of a 6.5. And then finally, there were 8 patients who were relapsing remitting, but a higher than a 6.5 EDSS, and those had a marked improvement as well. Next. So what that prior slide showed is it isn't the EDSS per se, it's whether it's relapsing remitting or not in terms of whether they'll improve. Because when we compared it with our secondary progressives, and I broke them into those that were active, that is within the last year, had gadolinium enhancing lesion, we did see a little improvement in EDSS, not much. Whereas those, about 54 that hadn't, no active new disease in the year prior to the transplant, their EDSS really did not change at all after the procedure. Next. So in summary, what I like to say is that there's a low risk of in-house neutropenic infections when you use a non-myeloablative regimen without mucositis. We've had no Epstein-Barr virus when you use ATG at a dose less than 6 milligrams per kilogram, unlike as have been reported in studies using higher doses, and you use an unselected graft in which you're giving back lymphocytes that you had mobilized. The first-year infections are mainly bacterial, less frequently viral, but they involve the upper respiratory as well as the urinary tracts. You should monitor patients yearly for thyroiditis, Graves' disease, or hypothyroidism, as well as make patients aware of ITP and to notify you immediately of any easy bruising. The incidence is markedly decreased if you avoid alemtuzumab, and of course, we do not CD34 select. Treatment-related mortality can be very low, and in fact, it would have been 0 if there had not been Legionella contamination in the hospital water supply. 5-year survival is greater than 99%. Next slide. And to continue the summary for relapsing remitting in these 414 patients, relapse-free survival was 80%, only 20% relapse after transplant. As you know, we stop all medications. They get no immune-based therapies. The progression-free survival is 95%. For newly diagnosed secondary progressive, the 5-year relapse-free survival looks great, 98%. But that's because those diseases normally burn out anyway, as well as maybe the therapy had an impact on that. But progression-free survival, I'm not, 33% still progressed, so I'm not sure that really improved progression-free survival, newly diagnosed secondary progressive. For relapsing remitting, EDSS improved at 5 years by over 1.5 points, almost 1.7 EDSS points or steps improvement for over 5 years. For the newly diagnosed active, that is within the last year, they had evidence of new MRI activity. The EDS improved by about 0.5 point, 0.6 if you want to round up, a lot different than with relapsing remitting. For newly diagnosed, again, these were sent to us as relapsing remitting, but they were secondary progressive MS, but they were not active within the last year. No new MRI lesions. The EDSS did not change at all significantly. Next slide. So summary, relapsing remitting MS active, newly diagnosed secondary progressive MS, non-active newly diagnosed secondary progressive MS respond differently to transplant. Results are confounded when studies mix relapsing remitting MS, active secondary progressive MS, and non-active secondary progressive MS within one study. Relapsing remitting MS demonstrates long-term remission and reversible disability without further treatment after non-myeloablative transplant for greater than 5 years. Now, an interesting thing is I'm involved in kind of writing up something else, that's another story, but I've been contacting patients we transplanted over 20 years ago, 18, 19, 21 years ago. We've lost contact with them. these MS patients are still in remission, have never started drugs, never had another relapse. So I'm very excited that maybe someday I'll find the time to give follow-up, long-term follow-up on these patients, because that's actually what we hope to achieve. So long ago, we never, ever, I never use the word cure, but once I start talking to patients where they're having remissions beyond 20 years, every single one I've contacted that were out beyond 18 years have been saying they've never had another attack, never got worse after getting better. You start thinking this changes the natural history for sure of this disease. Active secondary progressive MS should only have transplant performed in a randomized trial. We did see about a half a point, 0.6 improvement, but is that better than the natural history? I think to prove it, you really have to randomize with that specific subset. Do not include relapsing remitting and do not include non-active secondary progressive, which I would not give a transplant to. I don't believe that will help them, but if you want to, please do it in a randomized trial. Next. So I just want to say again that the key is patient selection and conditioning regimen. You can look at all our studies we've published at this website if you're interested. We put them there. You can pull down the PDF. Next. Next slide. And I just want to finish with a new book that will be out this November. It was a good 20 months of my life, as well as my colleagues here, especially Dominic Farge and John Snowden and Ricardo Siccardi, all of whom are on this meeting or will be shortly. And it's available hardback and electronic version. And if you want to pre-order, it's 650 pages. It has a whole section on all types of stem cells, including iPS, a whole section on immunotherapy, including CAR T cells and Tregs, and then a section on the autoimmune diseases, talking about each disease as well as results of transplant. Many people on this meeting, including the current chair and secretary of the Autoimmune Disease Working Party, contributed to this book. Finally, I want to say this figure cover I designed, but our IT person did it. There's a subliminal message in it. If you ever want to know, just ask me offline. Thank you.